Hello, well, welcome everybody. We're just it's great to have you at this NNAP webinar. The entry box or whatever we're calling it, the waiting room is bonging away. So we're gonna hold on for a minute or two and just allow the full participants crew to join us. You get that lovely bonging as and some familiar faces, so that's very nice to see. Most of you got your cameras off, very understandably. That's all good. Thank you all for being here. I'm for those of you who don't know me, there must be somebody who doesn't know me. I'm Sam Oddie. I'm a neonatologist in Bradford and West Yorkshire, and I'm the clinical lead for the National Neonatal Audit Programme. Shortly, I'm going to introduce Dr. Louise Anthony. Well, she's going to come in partway through, but behind the scenes, controlling everything, is Georgia Lewis, who's our NNAP project coordinator. If I got your job title right, Georgia, I would hate to get someone's job title wrong. That would be a bad way to start the afternoon. Welcome. Thank you for organising everything, Georgia. And also, possibly not visible to all the audience, is Humphrey Legg, who's our analyst, who I think might help me out if I don't know the answer to a question, and Robert Deuce, who's our NNAP project manager, program manager. It's project manager. I always get confused about those job sites, as is obvious. The bonging seems to have slowed down a bit, George. You think we should probably get going? What do you reckon?
Yeah, happy to start whenever you're ready, Sam.
Well, it's some many familiar names from the past here. I wish everyone's cameras on. It'd be much more fun, but it's not the correct answer, so I shan't do that. So I think we'll probably will get going. The aim of today really is for us to talk about the data assurance window and what that actually means. And what I'm hoping is that you can see a death by PowerPoint that should have appeared on your screen. Can I just confirm with Georgia or somebody that you can see that?
Yeah, that's great. Thanks, Sam.
Fantastic. Okay. Because I've been having some old person IT problems recently. Thank you all for being here, as I say. So we're going to talk for, if anyone's got the stomach for it, we'll probably keep online for about an hour, possibly just slightly more than that. And the aim of the game is to talk about the assurance window, and this webinar is designed to guide you through that. Louise, who works in Bristol, is going to talk about an aspect of this, but the aim of the game really is to talk about the data assurance process, how it works, and what's changed. I'm going to encourage you to think about the NNAP measures and what needs validation, and make a pitch about some things that you definitely should do some validation for, and how you should do that, and how in particular to use the RAD. Now, because you're all turned off, I can't ask you whether you know what the RAD is. But the RAD is the Restricted Access Dashboard, and I'm hoping that everybody on this call has already got access to the RAD. But if they haven't, if their NNAP lead was to email the NNAP email address, which is on the website, it's nnap@rcpch.ac.uk, with their local NNAP lead copied in, then they can get access to the RAD, and it's much more fun than the public access dashboard, which you can just Google. So during today, as I said, I'm going to talk most of the time. Louise is going to talk for a bit, and I'm going to come back, and I'm going to hopefully do questions, and the questions we've found are the most helpful part of this, which is why I'm trying to get off relatively quickly. And I'm going to finish up just by mentioning some important dates for the assurance process. So the first thing I wanted to make the point of is this is the first year when we haven't had the so-called quarterly reports. Those of you who've been doing this for a while, who perhaps wouldn't have joined this webinar if you know how to do this already, but we used to send out quarterly reports, and they used to look roughly like what's in the background on this slide. This pointed you at Badger and suggested that you clean the data up in Badger, and it made the point that the NNAP measures guide was a helpful tool when trying to understand what we measure in NNAP. Now, we're no longer having the quarterly reports. That's been replaced by the RAD. But the window is opening formally on Monday, and in fact, you could start cleaning your data today. But we won't be sending out so-called quarterly reports. We will do some comms, and the comms, I'm hoping, is ready. So that's a dead process. But the dead communication means the data assurance process is, and I want to make sure that my team do feel able to butt in if I say something that's not true, but I'm hoping that's something not true, but please do butt in if I say something that's not true. So the data assurance process, we've got a window, and that's basically a period of time when we know what your 2024 data looks like to us, and we're showing you what it looks like to us so that you can correct it if it's wrong. And the way that we want you to do that is to look at the RAD, the Restricted Access Dashboard that I've just mentioned. And we want you to use that this year as a way of working out what your data looks like to us so that you can correct it. Now, during the same period, we're going to send you a data assurance survey. I'm not going to say much more about that, but this is a survey which we ask about some measures in particular, an infection and brain injury and NEC. And we're particularly interested to know whether you think you've assured your data. And we're going to talk about assuring the data in a little bit. But this is a window of time that lasts 8 weeks or thereabouts. It'll be over on the 14th of March. And during that time, you can change your data in Badger, and then it will be reflected ultimately in the report. The report will be published later in the year. I'll come back to that. So what measures, what NNAP measures are included on the Restricted Access Dashboard? The answer should be all of them. And you can see that in this particular slide, we've divided them into different kinds of measure. I'm going to touch on all of these, but you should be able to see your rates of these different care processes and in some cases outcomes, and you actually see them over time. But importantly, and I'll show you an example of this, you can see what the data looks like for individual patients. And this is done in a very clever way that Humphrey designed. That means it's private to you, but you don't need a password, because we knew that, remember, so it was hard. Or rather, you only need your local Windows password. So all the measures are on the RAD, is the short answer to the question in the title. So what do you need to validate? Well, I'm going to tell you broadly speaking, what an understanding that has developed over time, and that's been based a little bit on what we do locally in my own trust, but why we do what we do. And so a bunch of different measures. So parental consultation, a famously popular NNAP measure, and the proportion of families who are spoken to within 24 hours of the baby's being admitted. Now, the number of patients involved in this is very large, and so I only review those that are missing or where the consultation hasn't taken place. And so I do review all of those. I have a ward clerk colleague who works with me on this. And we've managed to, and I then correct it if it's true that we did see the family, but I obviously don't lie because there'd be no point to that. Parents on ward rounds, I am not yet cleaning the data in Badger because I lack capacity to do that, if I'm honest. Breastfeeding data, breast milk feeding data, we find that they have very little missing data for this because I have a colleague who's extremely assiduous and good at doing this. But if there was any missing data, then I would be reviewing that, and I'll show you how to do that in the RAD before we finish today. So NNAP has some measures of care processes, and one of those is about 2-year follow-up. And I and one of my colleagues, Dr. Locke, reviews all of the cases where NNAP believe that we've not done follow-up. So we look back in, and I'm going to talk about that in a minute actually. And similarly, ROP, we look and see if the screening isn't recorded to have been done appropriately. Nurse staffing, we tend to have very complete data. This is not true for all trusts, but we're lucky that we have good primary data entry. So I review where there was missing data, but I don't currently go and see. There were supposed to be 11 nurses, and I don't check the primary record to see if there were genuinely 11 nurses, because in effect, Badger is our primary record. And the non-invasive breathing support measure, we didn't have any missing data previously, but I would review any missing data. So in my trust, and I suspect this is true for many, if not most trusts in England, we have a review process which looks at every baby less than 34 weeks to see whether they got their perinatal optimization, including breast milk, in the first couple of days. So there's relatively few cases where I have missing or unknown data. But any that were missing and unknown, I certainly would be reviewing. And any baby who appears to have a late temperature measured, that's likely to be a misrepresentation in Badger of what actually happened. And so I typically get the notes out. We use paper notes to review that. And similarly, I'll review any missing breast milk data, as I've just said. So for clinical outcomes, I know that I need to look at that data. I'm going to talk about this in a bit more detail. So start at the bottom. So we haven't had any missing mortality data in Bradford, and I think in Yorkshire for some time. But clearly, if there was a baby whose mortality outcome we hadn't described, I'd be keen to make sure we put that right. So I think I got a slide about most of this, but probably displays, yeah. I'm pretty sure there's a slide about that. So there are outcomes in NNAP, and in fact, bronchopulmonary dysplasia is a great example of that, where the baby, if the baby is born in Bradford, then and they get BPD, then that's counted as a Bradford case. It's not counted against Bradford, it's counted as a Bradford case, so it's attributed to Bradford. But clearly, a baby could be born in Bradford, have their early care in Bradford, but then be 36 weeks, and they might be in, I don't know, York or Calderdale or Airedale or somewhere. And so it's important that that trusts describe the outcome for patients who. So the data for Bradford would be described by what happened in another trust, and similarly, sometimes babies will be. We will be able to enter data that describes the outcome for a patient born somewhere else. So there's attributed to somewhere else. So sometimes I find I need to liaise with other hospitals in order to work out what the outcome was. And I'll try and talk about that with respect to NEP, with respect to necrotizing enterocolitis in a minute. So I've mentioned that ROP screening is something that we actively clean. I will go and review if necessary, the primary medical records for patients who have apparently not had on-time ROP screening. This has obviously got much easier because we've got better at doing on-time ROP screening, but we will sometimes look almost always in the medical records. Occasionally, we need to look in something called the ROP book. It's all very 1980s in Bradford. 2-year follow-up. I think I mentioned that we will clean. Dr. Locke cleans that data. She actually is responsible for the primary data entry, and it's therefore very good. But where we have a baby who's listed as not having been seen at 2 years corrected age, and by 2 years we mean between 18 and 36 months gestationally corrected age, she'll go and look in our electronic patient record system that we use for our outpatients and see whether a follow-up has been done and note that in the 2-year follow-up form. So we in that way we're able to describe what's actually happened. So bloodstream infection, this is as you know, this is a measure of the proportion of preterm babies, or very preterm infants less than 32 weeks, who have one or more positive blood cultures with a bloodstream with a bacterial pathogenic organism, or organisms likely clearly pathogenic organisms, the jargon we've used. So in order to do that, we need to know that every single positive blood culture has been entered in Badger. And I, not 10 minutes ago, opened an email from my colleague who has assured me that every positive blood culture has been entered into Badger. So I'm delighted that he's already done that for me. What a nice man Dr. Wallace is. So I said that we were going to get Louise on to talk about the process that they use in Bristol for Brizzle, I'm supposed to call it, I think, to talk about preterm brain injury. So without further ado, I'd like to introduce and thank Louise Anthony, who's talking to us really because some correspondence and meetings we had earlier in the year made it clear that that their team are exemplary, as well as being probably internationally known for their work on brain injury. They're also good at cleaning their data. So for that reason, and no pressure with that level of introduction, Louise. Do you want to overshare on top of me, so to speak? And I'll let you describe what you do in Bristol, if that's all right. You're muted.
Thank you,
No, you're not.
Sam. Can I just check, first of all, that everyone can hear me okay? Georgia, could you just confirm that that's okay?
I can hear you. That's
you can
loud
hear
and
me.
clear.
Perfect. And I'm just going to share my slides. One moment.
While you're sharing, I should have said, and I'm not sure I did say, if you've got questions, and we really do want to get questions, we have, for IT reasons, muted you, rather rudely, I think, but we've muted you. But please do put your questions in the chat, and we will pick them up. And all forms of messaging, but preferably the chat, are welcome. And we're always keen to communicate. Sorry, Louise, I've talked across you.
No worries at all. Thank you, Sam. Good afternoon, everyone. I'm really going to just talk very briefly, 5 or 10 minutes. Sam's been very kind and he's complimented us on the way that we clean our data. I have to be honest and say the whole reason that Sam knows about how well we clean our data is because of an error that we did actually also make. So I can't say that we are totally exonerated in this area, but I do think it would be really nice to share with you all how we do go about cleaning our data, and it'll be really interesting to hear how that fits with you and whether you think what we're doing is good or not. So specifically, I'm the NNAP and the VON lead for Bristol, and we've also got on the call Richard Baker, who's our data manager, who's actually completely integral in all of this, much more important than I am in dealing with all of this. So some questions might be directed at Richard as well. So Sam asked me specifically to talk about the brain injury data. So that's what I'm going to concentrate on. So specifically, there are 3, as I'm sure you're aware, components to the brain injury data, which are the 3 that are listed on the slide there. And in this unit, we specifically validate all of our preterm brain injury data. As Sam said, some of the other data entries, we may just use the missing ones, but for this and for the NEC, we have a different person for infection. I specifically look at every single case. So the first thing that I do, and this might be me being a little bit sort of, I don't know, geeky, but I always every year look at what the actual criteria are, which is for that's each specific component, because as I'm sure you're aware, it does change very slightly for different ones from year to year. For example, you know, the years that's attributed, this time it was babies who turned 44 weeks, and previously in previous years it's been slightly different to that. So I make sure that I've opened up, so to speak, the virtual booklet, and I'm absolutely clear, and I've reminded myself what the numerator is, what the denominator is. And particularly for the IVH, I just completely make sure I'm clear what the actual definition of the grading is, so that I know that I'm checking the right thing. And obviously it's really clear on the NNAP definition what that should be. And the reason I've chosen these 2 here is that I do think, obviously, this is the line for entry into the composite measure of grade 3 or 4 IVH. And obviously the differential sometimes between grade 2 and grade 3 is not quite as easy as it is on the pictures I've displayed here. And obviously sometimes you can have something that's a little bit more like this, which might need a little bit more thinking about and double checking against what the actual scan may have said. So for most of you, I'm sure you'll be adding it through this system, which is a method of entry of the scan results. Here in Bristol, we don't add it in this way, and I'll explain why, but that's sort of slightly irrelevant to the process that I use for checking it. I suppose the point I want to make is that even if you are a unit that does add it through this system, which I'm sure most will, I don't think that that necessarily means at all that it's going to be accurate, and we'll go into why I think that and whether you might agree or think I'm being a bit overreactive. So these are some of the reasons why I think it's probably not always accurate. So obviously, it's the most severe scan that you want within the first 28 days to be the one that's entered as the most severe grade. And sometimes that most severe scan may not be the one that's entered. Sometimes there's just simple scribing errors from one report across to another very easily. And 2s can look like 3s and all sorts of things can happen. Sometimes the actual images themselves can have been misreported by the person who's reported them, misinterpreted. Sometimes they can be a little bit borderline anyway and might need a bit more of an expert look at. And sometimes no results have been entered for one reason or another, particularly depending on how your individual unit enters its data, and we fall into that category quite a lot in Bristol for reasons that I will explain. So I've obviously scrubbed quite a lot of data on this screen because of data confidentiality. But essentially in Bristol, as you can see, I mean, this is just a small snapshot. We have a huge number of babies that come through here. But this is a small snapshot, and you can see that we have a lot of missing data or no scan missing IVH data. Now, our data manager, Richard, will take all of the information that we have on the RAD and he will de-anonymize it for me. And he de-anonymizes it and puts it into this table, which, as you can see, will have the baby's hospital number, has their date of birth, their weight, their gestational age, all the information that I need in order to be able to then look that baby up as an individual child on our system so that I can validate each of those scans. The reason that most of our scans are missing is because we don't have Badger as our primary sort of modus operandus here. We have a Philips ICCA intensive care system. We're linked with PICU and all the other intensive cares around the trust. And well, I'm not going to actually tell you how much I love it because I do absolutely love it. But the point is that we will enter all of our cranial ultrasound scans in real time through this system that does absolutely everything: notes, nursing notes, observations, everything. So once Richard has de-anonymized all of those babies, I will then go into our Philips system and I will look up. This is a slightly misrepresented version of our cranial ultrasound documents with all the identifying data taken out, but I will look through all of the ultrasound scans that each individual baby has had, and I will look at what it's graded at. And I will also then go into certain scans as well and look at the actual raw scans themselves. So I will particularly go into them if they say that they're a grade 2 or a grade 3 or a grade 4, because obviously that's getting towards the threshold where I might need to completely verify that. I will go into them if they look like they are edging near the 97th centile for post-hemorrhagic ventricular dilatation. And I will go into the scans if they look like they may have PVL on them as well. I will also go into them where it says at the bottom is scan is completed by and senior review done. If the senior review is not completed by a consultant, I will go into all of those scans as well and double check those. And then I will update Richard's table. This is just the tail end of the table with a sort of a Louise Anthony check, and I will write what I think I've graded all of those scans to be. And then Richard will re-enter that back for me, for us, back on the RAD again. And that's how I would check all of those sort of data. Similarly with the ventricular dilatation data, I mean, as you can see, I've done it all in one thing because I'm looking at the scans all at one time. But I think the pitfalls here are the checking the centile parameters. We're quite lucky in that our Philips system it pulls through for each individual baby what their 97th and 97 plus 4 millimeters parameter would be. But checking that, and also I will sometimes remeasure if the measurement looks a little bit dodgy and it doesn't look like it's been done in quite the right plane, as this one probably isn't. So I think that's a potential pitfall for that one. And for the cystic PVL, any baby that's got that they have cystic PVL or any cyst at all written on their report, I will check their scan and make sure I agree that it is actually representative of PVL and not representative of any other type of cyst. And actually, again, going back to the NNAP stuff, I will check each of them to make sure that the measure is as I remember it being. And also there's a really helpful definition within the measure for PVL of what PVL is and what a conatal cyst is to help you and remind you what you're looking at and what you're defining. So that's it, really. I do think accuracy is the key. If I'm not accurate with what I've put in, then we as a unit can't really benchmark ourselves or get anything back from the whole system. And that's how we do it here. So I'll end there. And then obviously, I don't know, Sam, what you would like to do. Would you like to save all questions, including my bit, to the end, or would you prefer?
If that's okay.
Yeah, of course.
If that's all right. Yeah.
Yeah.
That would be great. So brilliant. Thank you very much, Louise. So very much a kindred spirit, Louise. And thank you very much for describing what you do. How lovely to see your incredibly fancy intensive care management system. That looks great. And all the pulling through data, marvelous. I live in a slightly more 1980s world, as I was indicating. But that's great. So I'm going to skip over my next slides because Louise has covered some of that. And we do a similar thing to what I think Louise has been describing. But I'm gonna move past that. We can come back to it. And there's been some questions in the chat while we've been on, which is excellent. Please keep those questions coming. Like us and colleagues all over the country, Louise's team also clean the necrotizing enterocolitis cases. And in order to do that, it's not okay, as I indicated with the parental consultation, just to look at the missing data. That doesn't work. We find, like Louise in a brain injury, and Louise finds the same with NEC, you've got to look at every baby. So we look at all the eligible babies, and that's typically about 140 babies in Bradford, something like that. So I look at each case to check that they have been correctly described. So how do I do that? I look at the badge or letter, look at the headline diagnosis. I quickly read the summary letter text, and sometimes I'll read the subsections. It depends a little bit on the prior probability. If it's a 31-week, 1,700 gram baby, then I have a quick look at the headline diagnosis, a scan of the summary letter, and then leave it at that. If it's a 22-weeker who's been off and had multiple operations, then I'll read those subsections very carefully. I'll look at the radiology. I often, all years I've needed to correspond with people in surgical centres because we don't do surgery on my site. And I often have needed to engage with them to get them sometimes to amend their own data entry, or sometimes they're very clear about why they put what they put, but it's not obvious to me. So we've needed to do that kind of level of liaison with colleagues. So we do, well, I review every case. When I say I review, I try not to do it myself, but I actually generally end up doing that myself. How am I going to get that out this year? Because now we have the RAD, Humphrey's RAD. And this, as possibly those of you double devicing will have been doing during the meeting, you can use the patient list function to bring up, as you can see on the right-hand side, NEC is ticked here. And you can choose the period. Now clearly for cleaning 2024's data, you want to use the whole of 2024. And then I would be displaying all of these patients. And I will, I think, probably actually create a separate spreadsheet. I download this using the functions up here. And so sorry, I'm pointing as though it's obvious. I hope it is obvious. The top right-hand side of the RAD, you can download the data. I'll create a spreadsheet and I'll just go through those. I have a ward clerk colleague who turns the episode ID into hospital number in case I need it to look at the radiology, but generally I can get that by going through Badger. So that's the way that I do that. And then when I make a change to Badger, I actually record a column in my spreadsheet to show what changes I've made. I'm hoping for the glorious time when I no longer need to do this. But so far I've found both patients who are described as not having NEC, who do have NEC, and I've found patients often who are described as having had NEC who don't meet the surveillance definition for NEC, whatever people might have been worried about at a particular time in the course. So using the RAD, you can just go for missing, but as I've said, it's not just about looking at the missing patients. That won't quite cut it, but for other measures that might be important. Whoa, well, that's exciting, isn't it? So we'll go back and then we'll go down one slide at a time. So I mentioned I'd talk about some dates for the data assurance window. So the data was updated in the RAD this week. We're having a webinar today. The data assurance window is actually technically now open, but it's formally opening on Monday. There'll be a ceremony, a little prize giving. And the data assurance survey will send out the first iteration of that. And we're going to keep surveying you until you give us the answers. That'd be great. So thanks very much for joining in with that. And we're also going to be in touch with network leads to let them know about the state of data completeness in the networks. And there will be a further update of the RAD during this data assurance window to Wednesday the 12th of February. It answers one of the questions that came up in the chat. So if you change data in Badger, when will that be visible in the RAD? And the answer is 12th of February. But if you clean your data after the, I don't know, it's probably early hours of the morning on Wednesday the 12th of February, then the data will only be visible at the closure of the data assurance window. So come Friday the 14th of March, that's it. That's your chance. That was your chance to change your 2024 data. We're going to base our report on what we see in the data on the 14th of March. And it's I'm nearly off. I got distracted by the comments and the questions in the chat there. I must avoid that. It was actually Wednesday the 10th of February Monday the 10th of February that you need to have put your data into in order to affect the RAD update. So I was going to mention the 2023, this says, but we mean 2024 outlier measures. So we're going to have an outlier measure for IBH34 like we did this year, because there are some centres with very high rates of missing data. I'm not going to name any names in public, but you probably know who you are. So there are centres whose brain injury data is not complete, and that is important. It's important to us, but it's also important to the national ambition to reduce brain injury. So we're having an outline measure about ROP screening adherence. We have one about bloodstream infection, one about deferred cord clumping, one about magnesium sulfate, 2-year follow-up, NEC, BPD, and these are NEC and BPD, they're treatment effect measures, and the ability to keep everything normal temperature. I mean, it's subject to change, but I think hopefully that gives you a bit of a steer about our current thinking. And in effect, the metrics haven't really changed much since 2024. We will be including cases of PHVD. So if a baby was, and there are only a few, there do seem to be some, who are described as having a PHVD without having IBH34, then we will describe, they will include those in the numerator of the brain injury composite measure and therefore in the outcomes composite. I'm to try and take questions about any of those things. The measures guide, of course, is periodically updated. That you could just Google measures guide. So in summary, really, data validation window, it's open. We want you to look at your data so that we can all describe what's happened to the babies that we provide care for. We want you to use the RAD, the Restricted Access Dashboard. If you need additional colleagues to be logged into the RAD, it's easy to arrange that. Just email the email address on the page here. So we want you to review the completeness and the accuracy of your data. Based on my experience, I encourage you to share the workload with colleagues, and I'm super happy to try to answer any questions. Louise and I would be very happy to try to answer questions. And we're going to try to do the questions really relating to this sort of validation process, if that's okay. So are you marshalling questions, Georgia, or should I read through the chat? What's the best answer?
I've put together a little list, Sam, and I can pop that in the chat for you so you can kind of go through. One second. There's some of the questions that have come through so far.
Fantastic. So hopefully we've covered the first question around the if you get data in before the 10th of February, then it'll be updated as that Monday before the 12th February update. You're unable to edit the enteral feed data on the last day. So you might need to come back to, well, I think that sounds like a Badger issue, but you might need to come back to us by email just to sort of slightly clarify what that is if you're not getting any joy out of Badger, but I think that would be your first port of call. So I tried to address some of these in there. So there are definitely babies who move abroad, so can't have 2-year follow-up, for example. Or I think the example that's being referred to in the comment in the chat is a baby who might have been born in, I don't know, Dubai, and then ends up in a neonatal unit in the UK. And to where would they be attributed? The answer is they would be attributed according to the rules in the measures guide, because not because that's sort of convenient, or because we're reluctant to make exceptions, but because there's very large numbers of patients and we don't go around kind of altering patients' records individually. Of course, the number, they could potentially make a difference to individual units, numerators, and therefore their rates. The numbers, I think, will be very small. But the measures guide is basically the key to looking at those. So here's a question. If a mother had a complete course of antenatal steroids more than 7 days, but a second course, but only 1 dose before delivery, there is no specific area for recording the first dose. Oh, yes, there is. Which was complete. The first course was complete. Yes, okay, thank you. Sorry. So that so Badger doesn't provide to record multiple doses of antenatal steroids in the neonatal system. That's absolutely true. So we've sent out some comms about how we would like people to use the existing Badger fields to record the clinical situation that you described there. So this is all as a previous full course and then only gets 1 dose in the more recent course. That involves what I hope is a logical use of the existing fields. And there will be further minor iterations to the data entry, but that won't happen until March this year. So we have a case here described in a place. In one case, it went to a surgical centre. We found a Badger episode where an EC wasn't entered. And okay, no, I haven't come across that particular problem that you described between the Badger database not communicating correctly. That's not been a widespread problem that reported to us. One of the things about making secondary use of the data is that you definitely do get to hear about all sorts of problems people have with the way they interact with the digital systems, and sometimes more than one digital systems. And so we will keep our ears out for that. But it's fantastic to hear that you are communicating between trusts, because certainly my experience is that there are times when you need to do it, particularly if you work in a non-surgical unit, because you're what the colleagues write in surgical units then describes the outcome, which may be correct or may not be correct. It is sad that trust current EPR systems don't communicate well with BadgerNet. I agree. And it isn't manual, but it's definitely we're not all in the glorious future. There are people who live in quite a glorious future, but I absolutely accept it as a bit sad. BAPM have a position about that, and there is movement, but all these things take a long time. Why is the ability to export data in Excel disabled on the RAD? Humphrey, can you answer that question?
Hello, Sam. Yes, I can. I posted this in the chat as well. The download for Excel does not work in the platform at the moment. However, if you change the download option to CSV, it will download a file that can be used in Excel and should functionally work just the same as an Excel file if you open it using Excel. So that's the way it's working at the moment, but we will look into that, because it's quite confusing and annoying to have to sort of click through the various options to get to the download. We are aware of that.
I don't know if anyone else, when they were a child, used to watch a program called Stump the Scientist. Well, working with Humphrey, it's like, we'll stump the analyst. And it's pretty hard. Every now and then you can get him to say, I don't know, but most of the time he just knows the answer, even if you turn the camera off. Thank you very much for that very clear answer. Postcodes don't have an update on that. Any other comments, questions, please keep them coming in. How might Louise or I? So like Louise, I've certainly found there are cases, particularly where grade 2 and grade 3 IVHs are not, it might require some thought. And I occasionally go back to the radiologist and say, well, what exactly are you describing there? Because I'm not a great downloading data from the Badger dashboards doesn't seem to work on our unit. System C drew a blank, says James Rosenberg from the Royal Free. We would be very keen to encourage you to use the RAD, the NNAP Restricted Access Dashboard. If you Google NNAP dashboard, you'll find the PAD, and hopefully the slides will help you to find your way into the RAD. You need to get your local lead to email us, and we'll then give you permissions to see it. I hope that answers your question, James. Fantastic. So, Kristen Tenney said, wondering if units are treating new consultant ward round. It's not that new consultant ward round parameter. Both the parent and the consultant must be present on the ward round to get a tick. I can give an audit-based answer to that question, Kirsten, and you might not really have been asking me. I'm aware that with any NNAP measurement, there is sometimes a danger that people use the measurement to measure the thing they think it ought to be measuring, rather than the thing that it was actually trying to measure. And that's why we have the measures guide, which says very clearly what we're trying to measure. And yes, when we talk about, we have got a definition of what counts as a ward round, and it does involve a consultant on it. And we do understand that consultant ward rounds don't necessarily take place every day. The point of measuring it is not necessarily to say it should happen every day, but to try to illustrate the variation. There are lots of people who have problems with this particular measure, but from an NNAP perspective, what we were trying to measure was parental involvement in consultant ward rounds, because that's what the parents told us we should be measuring. And so we're trying to hold true to that ambition. But would we like to measure parental partnership even better? We would. That was a question. Other comments? Thank you, says Kirsten. We've silenced. My apologies for silencing you all. That doesn't seem very, very polite. Fantastic. Thank you all very much for your comments and questions. Cranial ultrasound scan data applies to babies discharged that year and those who turned 44 weeks to corrected age in that year. Is there a way to filter on Badger to find those babies who meet this 44 weeks babies criteria? Again, we would recommend that you use the RAD, James. I hope that's helpful feedback. If it's not, please put something in the chat or get in touch with us separately. That would be absolutely fine. We'll try to dig into that. So what we hope you will use the RAD for, this is one of our big intended takeaways from today, is the idea of the RAD was to show you what your data looks like to us, because that's what we're going to base the reporting on. So the data that we see, whether it's got the outcome, hasn't got the outcome, is that's what we're going to do the reporting on. So Kirsty Dixon had a question about present. She followed up Humphrey's, what I think might be an answer from Humphrey about that. Kirsty, did you want to come back on that? Not entirely sure I follow it because I haven't read Humphrey's answer.
I think that one's all sorted, Sam.
Okay, let's hope Kirsty agrees. If it doesn't go red with Kirsty says all sorted, marvellous, how marvellous, fabulous. Okay, well I think it's time for me to stop warbling on. Any further questions, please do type them in because it'll be going on. Louise, is there anything you'd like to observe? A broader question, says Susanna Kalowski. Why do we not align? Well, we think we do. So you might want to write to us. We don't align on breast milk because we think that the Saving Babies' Lives measure for Saving Babies' Lives was not deliverable. But otherwise, I'm not sure that we agree about that. But do you have my email address, Susanna? It's quite easy to find. But if you write to the NNAP inbox that's listed on my screen currently, you can get in touch with me that way. I'd be really keen to. Do you have anything you'd like to add, Louise? Thank you very much indeed for joining us.
You're welcome. No, I don't think so, unless there's any specific questions, but I think you've covered everything. Thank you, Sam.
Well, I thank all of you for the effort that you put into describing the outcomes for the babies. I think it's really important and valuable work, and I think the families are grateful to you for doing it. So thank you very much indeed for attending our webinar. I'm going to get off before you all fall asleep. But thank you all very much indeed. And we'll probably stop the recording at this point and wish you all a nice evening. Thanks for joining.